Good evening, everybody. I think already we are nearly half a century of people into this session. So we'll just wait for maybe another 60 seconds to 90 seconds before we start. It's a pleasure and privilege to have everybody in. And I can already see that there are quite a few of the people for whom it is intended for. Essentially, it all started with the students of Apollo Gleneagles Hospitals, Kolkata, the DNB trainees at Apollo. But yeah, I think over the last couple of months, it has expanded, and we find that from the friends of the students that we have, it has reached to a lot more people. And we are planning to have this, we're trying to have this, rather, I won't say it is anymore in the planning thing. We're trying to have this every Friday. So let's see how far we go. And, the 1912 pandemic got the renaissance going for the whole world. I think this pandemic has given this modality of teaching and training to us. What I think, just I'll take you through, and possibly we will have a feedback from all of you later on. And I think I'll begin initially by thanking HCP Forum and especially Dr. Jayati for handling the entire back room and handling the setting up of this webinar. And she has been extremely helpful. She has the patience and the willingness to kind of take everyone through the route, and she's been also willing to help people in how to register, etc. So we would just ask you, I think, to at the end of the session, please, you will receive a mail from HCP Forum. Please do fill up the mail, and we want to figure out how easy or how difficult the registration process is, so that we can try and make it better as days goes by. So I think we are good to go. We are hit 75 people. So I think Palash, I think we are good to go. So the agenda for today would be that Dr. Palash Kumar. Palash is a great friend of mine for a long time now. I've been knowing Palash since he was a student of anesthesia, though pursuing his MD, and then he came and joined our department, and he was one of the bright stars of the department. He has helped in the progress of the Department of Anesthesia at Apollo. Huge contribution towards the progress, both clinically as well as academically. And then we started our own initiative like the Kolkata Anesthesia Academy. He has been he has had a huge role to play. So today, Palash will first take you through the investigations. The theme for this evening is the lungs, the pulmonary thing. And so he will take you through, and you can figure out that most of our sessions are kind of focused at postgraduate teaching, but it has obviously huge implications for people who are in practicing anesthesia as well. So Palash will take you through the basic tenets of chest X-rays, pulmonary function tests, and something which is new, which is cardiopulmonary exercise testing. So he will take you through that. And then we will have the question answer session on that topic, that is Palash's topic, on chest X-ray, PFT or CPT. And if you have to ask anything else, please type in your question and in the chat box. You can see that there is a chat box for you. So please type in your question at the chat box. At the end of the first session, we'll have the question answer. And then I will take over and I will take you through essentially preoperative evaluation of risk factors. And we will speak about non-thoracic surgeries, pulmonary evaluation, and a little bit about how you can optimize prior to taking that patient up for surgery. So without further ado, Palash, by the time you start speaking, I think we will hit the 3-figure mark. So please take over, and I you over to Dr. Palash Kumar, who is currently a consultant anesthesiologist in the Department of Anesthesia at the Woodlands Super Speciality Hospitals, Kolkata. Palash, all yours.
Yeah, thank you, Shrekadda. And I must say that after I passed out my MD, Shrekadda has been sort of my idol and mentor, at the same point of time. And we have spent a lot of time together. We have used to conduct these kinds of sessions on a physical basis, mostly with students. But here, because of this lockdown and all these things, we can now uh, entertain an audience which is larger. There are drawbacks as well. It's not as interactive as it is when I'm facing an audience and talking to them directly. So there are drawbacks and also. So the three things that we'll be touching today in this first session, one is basic interpretation of chest X-ray. So we're not going to look at a large number of X-rays and find a correct differential diagnosis. What we are going to do is to establish a framework for looking at an X-ray and establishing a sort of a guideline. Just like when we look at an ECG, we look at point this, and we come to a conclusion. Similarly, we need to do such a thing for X-rays also. We must have read about X-rays during our MBBS days, but during our MD days, the emphasis on X-ray is not so much. And also in our present clinical practice, most of the time, any patient with significant lung disease, we tend to get a CT or even an HRCT. But X-ray is a basic investigation. Not all patients can actually undergo a CT scan at all possible times. So chest X-ray remains a very valuable test which you often prescribe. So a brief overview of that. And then we will also have a brief overview of PFT, how to look at an PFT and what are the informations that we can get from a PFT, and CPEX, which is cardiopulmonary exercise testing, which is a big thing now. And at least in our part of the world, we are not using it CPEX, but CPEX is quite widely used in the first world countries. And this cardiovascular fitness, it is one of the measurements, very valid and important measurements of cardiovascular fitness. And cardiovascular fitness is one of the most important determinants of our length of our life, whether long or short. So CPEX is important. So all three things will be touching around. So first I will begin with the chest X-ray. Okay. This slide set is courtesy Dr. Shoikat Sengupta. He had prepared it, most of it. I have just made a few small adjustments to it. So please have a look at this chest X-ray. We will come back to this X-ray and combine whatever we have learned in the next 15-20 minutes and see what is the interpretation of this X-ray. Not a very difficult one, but there's a rather interesting twist to it. Okay, so first is ordering a chest X-ray. We often order chest X-rays for a patient, and most of the time, at least what I do most of the time, I just write CXR. I'm guilty of that, I must admit. So I do not properly prescribe a chest X-ray. So these are the steps that we must follow when we establish, or when we prescribe or write a chest X-ray. One is that we must identify the patient and writing it for the proper patient. It's important when we are seeing a patient in the wards, then we are writing it for the correct patient. Indications for the procedure, we should know why we're offering it. Often we just write a chest X-ray just because anybody is old, or just because somebody is old, or from some very small complaint, but chest X-ray should be reserved only for patients who deserve it. We're not going into detail for indications of chest X-ray. What you have to write is the position in which we want the chest X-ray to be done. It can be done either in the supine position or in the erect position. If it is anything is not said, then you have to assume that the X-ray is to be taken in the erect position. However, there are certain, especially for patients who are very sick or has a trauma or sick lying in an intensive care bed, it may not be possible for them to take an erect chest X-ray. In those patients, a supine X-ray will be indicated. The other thing is anterior posterior view or a posterior anterior view. If anything is not specified, then the X-ray should be a posterior anterior view. That means the chest X-ray would be coming from the posterior aspect and going towards the anterior aspect, and the X-ray film, nowadays there is no film, just a digital receptor, just like our cameras. So that lies anterior to the chest. There is a gap between the person, the X-ray generator and the person, and the film or the receiver or the whatever, let's call it the film. The film is kept flushed with the patient's chest and the patient stands erect. If we are taking the X-ray in a supine position, then it will be an anterior posterior view. That is, the chest X-ray film will be behind the patient or in approximation with the patient's back. Usually we, if anything is not specified, then the chest X-ray is taken in an end inspiration, because end inspiration inflates the lungs and we want the lungs to be nicely visualized. However, there are certain situations when you want an end expiration, that means less amount of air within the thoracic cavity, especially if we want to detect some abnormal air somewhere. So if we can reduce the normal air inside the lung and increase its density, then abnormal air, there is a contrast between these two things. Anything that is visible on a chest X-ray depends upon the contrast between two adjacent pieces of tissue. So if the patient is suspected of having a pneumothorax or atelectasis or some kind of air trapping, then an X-ray in an end expiration position at the end of expiration is justified. Well, shades of gray, not exactly 50, but only a few ones. This is a rough guideline towards looking at a chest X-ray and looking at the shadow. It's a gray scale, what is to be expected depending on the kind of shadows. On the very left, we have a black area, that means it is a completely radiolucent area. So that means what is there is air. And if it is a dark gray, then it is also very lucent, and the most likely tissues is fat. So we'll find fats around the skin areas and that. Soft tissue is lighter gray, like the heart and some of the blood vessels, etc. would be softer tissues. Bone would be almost near to white, slightly off-white, and something which is the whitest would be a piece of metal. There are various things which are implanted in the chest, so they will appear as white. We can also have artifacts like coins in the patient's pocket or maduli or tabik, this kind of stuff, or foreign bodies like bullets or ingested materials anywhere within the thoracic cavity. So this must be kept in mind when we are interpreting an X-ray. So how do we begin to interpret an chest X-ray? This is a stepwise approach. First, you have to confirm the details, patient, in which position the X-ray was taken. Then we have to confirm or see that the image quality of that chest, the image quality of that X-ray must be good for us to interpret it. Then we have to do a systematic examination to come to a conclusion. Here we will follow an ABCDA method: airway, breathing, circulation. That means circulation would be heart and the great vessels, mostly the heart. D for diaphragm, and then everything else. There is another approach which is followed, which is inside out approach. Then the examination begins at the center of that chest and then goes to the periphery. But this is quite convenient. We are used to ABC following this dictum and algorithm most of the places. So we'll follow that. So patient's name and date of birth, date and time the film was taken. These things should ideally be printed on the chest X-ray. There is a tag which is placed, which usually has some kind of patient identifier and date and time the film of the taken. And there is also something else is usually there. A side marker is there. So a left or right L or R mark would be there to indicate which side of the patient is there. But we have actually we cannot verify whether this left and right is correct. I have faced X-rays in which the left and right was wrongly, that was in the wrong place. So left appears as right, right appears as left. So you have to be careful. If you feel that there is a possibility, then you will have to cross-check. Any previous imaging, if present, should be available for comparison. Now we come to the assessing of the imaging quality. Now here also we'll use an acronym. It's called RIPE. So R is for rotation. Now when we're taking an X-ray, the patient should be in erect posture and the patient faces a very flat wall and is almost pressed on this film. However, if this optimal position is not achievable due to whatever reason, patients having pain, patients having trauma, patients having deformity, or in chest X-ray in a supine position, patient lying down on a soft bed, there is a possibility that the X-ray may be rotated. So the two things that we must note, one is the medial aspect of each clavicle should be equidistant from the spinous process, and the spinous processes should also be vertically oriented against the vertebral body. I, ripe, or I is for inspiration. So we have to confirm that the X-ray was taken in inspiration. If they're taken in inspiration, that is with inflated lungs, we'll be able to see 5 to 6 of the anterior ribs, that's their shadows, both the apex of the both right and left lung, both costophrenic angles, and the entire lateral rib edges should be visible. P for projection, whether it's an AP versus PA fill. If there is no label, we'll assume that it is the standard X-ray, that is a PA view. If it's a PA view, then also there are certain things that we can see in the chest X-ray, that the scapula are usually not projecting inside the chest, so they end usually around the costal margins, and both the lung apex is visible over the clavicle. And if it's a PA X-ray, then usually lung over the clavicle is not visible, and quite a large part of the scapula comes inside the lung fields. If we see ECG wears or shadows which are likely to be ECG wears, then patient was probably supine, and hence an AP X-ray we have to conclude. The last letter for ripe is E for exposure. How do we know that the exposure was proper? All of us have worked with orthopedic surgeons, and we can see that how visibly perturbed they get when their exposure is not right. So they increase voltage and this and that. So we have to know if the exposure for our X-ray is correct. So if our exposure is correct, we should be able to visit the whole of the hemidiaphragm to the spine. In the medial aspect of the spine, where it ends on the spine, we should be able to see, and we should be able to identify the vertebra behind the heart. Now this part, vertebra behind the heart should also be visible. We should also be able to visualize the cardiac contours and also the vertebra and the intervertebral spaces if the X-ray is properly exposed. If we have an hyperexposed thing, then the heart shadow will be barely visible and the vertebral shadow will be much more prominent. So let us look at this X-ray. Here we can see that the R part ripe, so rotation. So medial aspect of each clavicle here and here, they are almost equidistant from the midline, from the spinous process, and the spinous process are vertically oriented. So these spinous processes are vertically oriented and are in a straight line. So we know that this X-ray was not rotated when this was taken. Now I for anterior ribs and both the lung apex, you can see that both the lung apex is visible above this clavicle and anterior ribs. Now, if we look at the ribs on this side, we will see that there are some ribs which are mostly horizontal, and there are some rib shadows which are curved. So these curved rib shadows are anterior ribs. So first, second, third, fourth, fifth, and sixth. So the 6 anterior ribs are visible on this X-ray, and the lateral margins of the rib cages also are visible. The lateral margin is nicely visible and within the field of that X-ray. So I is also correct. Then P. Now the projection, here you can see that the scapula is not coming inside the lung. So it's a PA view. And also exposure is correct because this left hemidiaphragm is coming right up to this vertebral border. We can see the right hemidiaphragm. And if we look at the vertebral shadows behind the heart, we can clearly see the vertebral shadows and even the intervertebral spaces. And also the cardiac contours are clearly visible. So this is an example of a properly exposed X-ray. Now we begin our systematic examination, beginning with the airway. So trachea, Is the trachea significantly deviated? That's the first thing that we see. We also examine the deviation of trachea, but the trachea in an X-ray we can visualize which extends into the thorax. So if it is normally located centrally or just slightly off to the right, its normal position is maybe centrally or slightly off to the right, but it has to be vertically downward. Now the deviation is more important. If it is deviated, look for anything that could be either pushing, that is a mass, or pulling, that is a fibrosis or something, to either side. Also inspect the paratracheal masses or lymphadenopathy if there are opacities, dense opacities by the side of the trachea. Now, here is the trachea that we can see, and we can see that there is a huge opacity. This border of the lung is not visible. So just going back to the old slide when I talked about the different shades of gray that we are going to see, whenever we are seeing something on an X-ray, the border between two things like these ribs we are seeing, because there is a difference on the densities. So if something happens which changes a density, then we will not see that border. So we should be seeing a cardiac border somewhere around here, but we are not seeing because the density of the lung or whatever, the pleural space has increased because of accumulation of fluid. So this thing is causing this border of this heart to get blunted because it is blending in, and there is similar X-ray patterns. The shadows are similar of depth, so we cannot see that border. What we see is a huge white shadow. Now this position of the trachea here, it gives us some idea, because as you can see that the trachea is, instead of going directly vertically downward, it is somewhat deviating towards this. Here is the carina. So from here there is a slight deviation of the trachea, the right and the left mainstream bronchus. So this is causing a little bit of tracheal deviation. Now carina and bronchi. The carina is located at the point in which the trachea divides into the left and right main bronchus. On a good quality chest X-ray, this division should be visible and is an important landmark when assessing a nasogastric tube placement, as the NG tube should bisect the carina if it is correctly placed and not in the airway. So in an exam table, you can actually get an X-ray with a nasogastric tube, and there can be bizarre X-rays. People can have different collections, but what you should keep in mind is that it should not go along any one of the airways. The right main bronchus is generally wider, shorter, and more vertical than the left mainstream bronchus. So any inhaled foreign body can become lost there. But any foreign body with the Ryle's tube can take either left or the right pathway. So here we have the left and right mainstream bronchus, and here is the carina that you can see. This is the borders of the two mainstream bronchi. So the carina, this is the position of the carina, which is clearly visible. So if a nasogastric tube is going to the right way, it should pass somewhere between like this. So a Ryle's tube going this way or that way might have ended up in a lung. And also a properly placed Ryle's tube tip would go below the diaphragm. Hilar structures. So we have got lots of blood vessels and lymph nodes, etc. in the hilar structure. It's the pulmonary vessels and the major bronchi. Also the collection of lymph nodes, which are not usually visible in healthy individuals. So it's very difficult to interpret whatever in hilar structures. I often find that there is some opacity, small opacities are visible in the hilar structure because people tend to have lots of respiratory infections and lymph nodes may be slightly enlarged. So this is the left hilar point, which is slightly higher up, as the left bronchus deviates at a greater angle and branches earlier, and the right sorry, not earlier, but it's at a higher angle, greater angle compared to the right mainstream bronchus. The right hilar point is slightly lower than the left hilar point. Now, how do I assess if the patient was at the end inspiration point? So lungs, no, sorry, we are talking about the breathing. Breathing part, which means that we are going to examine the lung parenchyma. So A, airway, then B, breathing. Breathing basically is the examination of the lungs. So we make hypothetical divisions of the lung into 3 zones of each side, and inspect them individually. And when we inspect them, we match the left side with the right side. If we have any doubt, we match the left side with the right side, like you do in a CT scan. If there is any difference in opacities in the left and the right zone, we should be trying to figure out if something is wrong. If there is an increased airspace shadowing, that means increased blackness in a given area, may suggest a pathology. So shadowing is, sorry, whitening, so consolidation or malignant lesion. If there is a complete absence of lung marking, if there is no fine white markings there, it's completely black, then it can be a segment without any lung tissue, and the chances of pneumothorax should be suspected. Here is a lung X-ray. There is increased bronchovascular markings on both sides, and there is a large opacity with an irregular jagged edge on the left side. So it's most likely diagnosis is a malignant tumor of the left side. Here is another X-ray. Here you see the opacity. It's more homogeneous, and it seems to have more defined borders, and it seems to be like a three-dimensional structure. So it is more likely a consolidation. You also please note that this X-ray exhibits that there are X-ray wares. They're wares like this. So these are probably taken in supine position, and you must also appreciate that the lung fields appear really small. So this can be X-ray taken in a supine position, and you can see that there is not much lung shadow visible over this clavicle here. So slight rotation also, because there is some little bit of lung shadow available here, and this is much closer to the left clavicle than to the right clavicle. So the patient is slightly rotated when this X-ray was taken. This is probably a pneumonitic lesion. Patient has a pneumonia. Breathing. So we continue with breathing, and we look at the pleura. Pleura is normally not visible. It is a very thin structure. So unless there is an abnormality which causes a pleural thickening or a tumor or something like that, the pleura is not going to be visible. So you have to inspect the borders of the H lung, because that's where the pleura is going to be, to ensure that lung markings extend all the way up to the edges of the lung field. If there appears to be an area lacking lung markings with decreased density, this might suggest that there is a pneumothorax. Continuing with pleura, if there is fluid or blood, hydrothorax or hemothorax, both will behave in a similar fashion, will have a dense opacity. If the patient is standing, we may have an horizontal border if there is a little bit of air on top of it. So we can have an area of increased opacity with a combination of both pneumothorax and a fluid, hydropneumothorax. And it can be in a pleural fluid also, it can be inside the cyst also. We can have both air and air fluid levels. So if we have an air fluid level, it is better for us to appreciate an air fluid level if we have an X-ray taken in an erect posture. In that case, air would move up, and the fluid, whatever, blood or pus or fluid, exudative or transudative, whatever it is, it will settle to the and give us a more sharper margin between this dark area of air and the denser area of the fluid. So here we have an X-ray. If we compare the lung fields in both these areas, we can see that this area is almost black. There is a little bit of small graininess, but that is uniform graininess. It's probably a problem with the developing or printing of this film. And here you can see clearly the small white lines. These are the lung markings. Here it is completely absent. Now, if we move more towards its hilar area, we can see a clear, nice, clear line, which is the pleural line. So whole of this right lung has collapsed into this part, and we have a whole right-sided pneumothorax in this patient. Now, is it possible for us to tell that whether this patient has just a pneumothorax or has a tension pneumothorax? It's maybe possible, but it's usually not possible, because tension pneumothorax is a pneumothorax with hemodynamic instability. That is, it's mostly a clinical diagnosis. However, in certain cases, in the presence of a gross pressure difference between the two sides, we might actually see there is a tracheal deviation kind of thing. But that is also not conclusive. Here we have an X-ray. Here we can see that both the edges lung field, there are quite a bit of opacities around the hilar areas, and there is a thickened band-like structure here. This is a patient with a mesothelioma and pleural thickening. Here also, one important thing to look for is obviously to take the patient's history. Patient has any history of exposure which is consistent with development of increased risk of development of mesothelioma, that should be looked into. C for circulation, mostly cardiac. First thing we do is to assess the heart size. So in a healthy individual, the heart should occupy no more than 50% of the thoracic width, that is a CT ratio of less than 0.5. This rule only applies to the PA chest X-rays because AP films will exaggerate the heart size. There are certain other abnormalities that happens with AP films as well. We've talked about the overall size of the lung being small. And since the overall size of the lung being small, and in that case, the amount of air that is in the lung is less and lungs are denser, they become denser. When they become smaller, lungs become denser. So it appears that the patient has patchy opacities when you take a supine X-ray. Then what happens, that patient thinks that we have got an infiltrative pneumonia bilateral, the patient has a CT or an erect X-ray and it comes out as clear. So if we have patchy infiltrates on a supine X-ray, we must be careful about interpreting the patient's having an infiltrative pneumonia or any infiltrative disorder. It also widens the mediastinum if we have an AP film. So we can assess the heart size only in a properly taken film, the PA film. If the heart occupies more than 50% of the width in a PA X-ray, then this suggests abnormal enlargement, cardiomegaly, many diseases, valvular disease, cardiomyopathies, pulmonary hypertension, and pericardial effusion. The features of left and right heart enlargement are slightly different, but we are not discussing it here. But you should read it, how to differentiate between right and left heart enlargement. This is an example how you measure the cardiothoracic ratio. Just take a scale, measure the width of the heart at the widest point, just like you measure our abdominal girth, and you take the thoracic width and just get the ratio. Here you can see it is just below 0.5. Now here is an example where the heart shadow is quite large. Now here is one thing, when you decide that this is an heart shadow, you see that we can actually see almost to the end of this left postophrenic angle. It is slightly blunted. There may be a small amount of fluid here. And this is also not very clear. There is a bit of haziness, but we can clearly see that the heart has ended here and there is some lung tissue here. Also, to give us some hint that we have a pacemaker here, we've got two leads getting into, one into atrium and one into the right ventricle. So a patient has a double chamber pacemaker in place. So has some cardiac abnormalities. Assess the heart borders. Inspect the borders of the heart, which should be well defined in healthy individuals. Obviously, to assess the heart, there should be difference with if there is any lung consolidation or accumulation of fluid. We will not be able to assess the heart borders very well. The right atrium makes up most of the right heart border. The right heart border is almost a vertical line on the right side of the vertebral column. So this is mostly made up of the right atrium. The bottom part is mostly made up of the right ventricle, and the left ventricle makes up more of the left border. And what we can see above that is the aortic knuckle, and we can see the pulmonary bay, and then the left atricular appendages on the left side from top to bottom. The bottom part is, of course, the left ventricle. Now, if we are not able to clearly visualize the right border, then probably there is some middle lobe consolidation is there, because the density of that lung has increased, lung water has increased, it has become whiter, and the contrast between the heart border and the lung tissue is lost. Similarly, the loss of definition of the left heart border is most commonly associated with a lingular consolidation. But we have also seen that if there is a significantly large pleural effusion, then also we lose the left heart border definition. Mediastinal contours, it's very difficult to interpret. The thing that we should be clearly looking at, if it's looking width is looking normal or if the width is abnormal. So on the top portion, what we can see, you can see in an old person, we can actually see calcium plaques there. If there's calcification of the aorta, sometimes the contours of the aorta can be visible. It contains the heart, the great vessels, and lymphoid tissue. The exact boundaries are not visible, but these important structures are there, most important being the aorta. So the aortic knuckle, the left lateral edge of the aorta, we will see one example later where we point out the areas. The left lateral edge of the aorta, this arches back over the left bronchus, is visible as the aortic knuckle. And if there is a loss of definition of the aortic knuckle, it can be caused by an aneurysm. Aortopulmonary window, there is a slight concavity between the aortic knuckle and the pulmonary bay. This is called the aortopulmonary window. So this is lost there if there is mediastinal lymphadenopathy. So here is an example X-ray where we can see this. So this is the aortic arch coming up from the right side, bending over and going down, descending aorta. So this white portion, as you can see, this is the aortic knuckle, and the pulmonary area is here. Below that is the left atrial appendage, and here is the left ventricular border. This right side almost fully is the right atrium. So, and this is this gap area, this blackish area is the aortopulmonary window. So if this is this concave line you cannot see, and then it's one possibility that there are mediastinal lymph nodes can point towards malignancy. Now ABC, now we come to D, diaphragm. There are two diaphragms, right and left. The right diaphragm is slightly elevated because of the presence of the liver. The density of the liver and the diaphragm is so that we cannot separate the diaphragm from the liver. The whole thing appears as a white opacity. On the left side, there is a stomach below the left hemidiaphragm, and we can sometimes appreciate the stomach because of the fundal air. If we see a black shadow, that tells us that this is the fundic black shadow. On the right side, we can visualize a separation. If we can visualize a black shadow between the liver and the diaphragm, a chink of black shadow, that means there is free gas is present. So that is a sign of the bowel perforation. But for this X-ray sign to be visible, we have to take an X-ray in the erect posture, which is often difficult in a patient who has significant pain. However, gas under the diaphragm is diagnostic of bowel perforation. However, there is this is a case where you can see gas in the diaphragm. This is the fundic gas shadow. This left diaphragm is clearly visible. Here, this black shadow is the fundic gas shadow. And if we go to the next one, this is a quite interesting X-ray. Here we can see quite a bit of black shadows here between the diaphragm and liver, somewhere around here. The fundic gas shadow is very properly preserved. But here, this is not a case of gas under diaphragm. If we look clearly, you can see this white septa, which it looks like a large bowel shadow. And this is a specific thing called Chilaiditi syndrome. This is pretty rare, so we're not going to find this often. Continuing with the diaphragm claustrophrenic angles, this is something that we look very often, and it gives us important clues. They are formed at the dome of each diaphragm and the lateral chest wall. In a healthy individual, they would be an acute angle. So if they are not in an acute angle, or if they are not visible, they're abnormal. So this loss of acute angle is known as claustrophrenic blunting. We are pretty fond of this term. This can suggest that there is a presence of fluid or consolidation in that area. It can also occur if the diaphragms are flat and the angles become obtuse as a result of diaphragmatic flattening, which happens in COPD. Here we have a look at an X-ray. We can see that this right side heart shadow is quite preserved. The right claustrophrenic angle is quite nicely visible, that there is a blunting of this left claustrophrenic angle shadow is there. And after we have finished, we come to E, which is everything else. We look at the bones, the skeletal structures, looking for any abnormalities. So we have to systematically go through the ribs. Actually, how much we examine also partly depends upon the history of that patient. If there is a history of trauma, then we look at the bones, the ribs very clearly. Whatever possible, we look at the spine also well. We also look for lytic lesions. Lytic lesions would appear as a blackish, roundish area within the flat bones, the scapula and the ribs. So the lytic lesions can be present in case of many malignancies. Soft tissues, in fact, the soft tissues for an obvious abnormality, if there is a large hematoma. One of the things that we can sometimes figure out is air inside fat after laparoscopic surgery. Sometimes we can find air in the fat layers. Other things which are foreign bodies, commonly we find tubes, pacemaker, and valves. Tubes like nasogastric tubes, you will be asked, and if it's safe for feeding, we've talked about that. We can have a central line, we can have ECG cables, we can have other sorts of lines coming in. For example, a chemoport, we'll have to identify that. We'll have to maybe ask about where the tube is ending, if this is appropriate or not. Artificial valves, aortic or any metallic valve will become apparent as a bright white shadow. Pacemaker has a distinct uh, kind of shadow. Pacemaker, the whole of the pacemaker seems to be I mean, the whole thing is not radio opaque. It is mostly radiolucent, and we can clearly see different structures inside this thing. There is semilunar white structure, which is the battery, and the electronic circuit is visible, and it is often possible to identify the pacemaker. Now, the name is usually not visible, but there are codes and structures within that printed circuit board or the circuit which can be identified by the person who knows how to identify what the brand of the pacemaker. So let us come back to this chest X-ray and let us go through what we have learned in this case. Now, what we can see here is there is, as you can see, that there is this one blackened portion here, black portion here, a black band. So this is not an artifact. This is has been done to maintain patient confidentiality. So we can expect to see the patient's name and any other identifiers, maybe the date and also. So I've got chest X-ray in erect posture, and we do not know which is the left side and the right side, but from the cardiac shadow we'll make a guess, and in a normal case this is going to be the left side. Okay, so the first A is we look at the okay, first thing we'll look at ripe. So rotation wise we can see that the spinous processes are nicely in a midline and a straight line. Trachea is a nice straight line, and this edges of both the sides of this clavicle are nearly equidistant from it. So this is not taken in a rotation posture. Now we look at other things. We can, how many ribs in we can see. So we can see front ribs, the carved ones, 1, 2, 3, 4, 5, and part of the sixth rib. So inspiration. Now we look at the other two things, and the exposure part. We can confirm the exposure part rightly also. Uh, it is visible to me. I'm not sure if it is visible to you, but I can clearly see the intervertebral spaces, not all of them clearly. So the exposure is also nice. So now we will move towards interpretation of that X-ray. First, trachea, we can see very clearly that the trachea is completely in the midline. Here is the carina. Trachea is nicely in the midline. Now, we will look at the lung shadows. If we look at lung shadows on both the sides, they're quite uniform. There's a little bit of increased bronchovascular margins, but nothing too serious. And cardiac shadow, if we look at the cardiac shadow, I'm not very sure if you can appreciate it. There is a cardiac border which comes around here, and there is a shadow that goes up to this area. So there is some white shadow on this side. Cardiac ratio seems to be here. The cardiac ratio seems to be about 0.5. And then we look at the diaphragms. We can see both these diaphragms. Both costophrenic, this costophrenic angle is nicely visible, this costophrenic angle is not so, it's somewhat visible here, but there is a shadowing over here. And we have this instrument, this particular X-ray we have given it because this particular X-ray, now we have to identify what device is this. I'm not very sure if you can see it very clearly, but there are electrodes coming out of it, and this is the electrode, and then some kind of structure over here, and then the wires are going like this. So this is not a pacemaker, this is a vagal nerve stimulator. So lung volumes are reduced. Okay, erect posture, so the lung volumes are reduced. In a supine position, we shouldn't have said that. There's a bit of basal haziness. normal borders, normal city ratio, then there is a vagal nerve stimulator. So this is a basic approach to how to see and a chest X-ray. So we will end it here, and please keep your write your questions and put it in the chat box. We will take all the questions at the uh, end of this session. So we will go to our next presentation, which is now next to a sort of a lot of assessment of a practical assessment of a patient, and sort of we'll continue this theme into the second session about which will be taken by Dr. Sen Gupta. So let us talk about pulmonary function test. Uh, it's an overview of pulmonary function test. All these topics are quite large, so let's try to see whatever I can cover. It's a group of tests used together to assess lung function. This definition, it is not exactly a definition. I try to find if they can get a nice definition to lung function test. So pulmonary function test, I couldn't find anything. So this is what the impression that I got. We use a bunch of tests together to assess lung function. We will mostly confine ourselves to spirometry and the associated tests that we usually get. But other large number of other tests we also use to assess lung function. Namely, we use plethysmography to take saturation. We use an ABG often, and also we use CPEX, cardiopulmonary function exercise test. So we'll use that together. But here we'll mostly confine to spirometry and other things. So what are the indications of doing a pulmonary function test? Now, we can do it as an investigation of patients who has signs and symptoms that suggest a pulmonary disease, like dyspnea or cough, has an abnormal X-ray, or any other pulmonary sign, or has a wheeze. We put a stethoscope and we find abnormal sound. So we can use a pulmonary function test in those patients to investigate, to find out what is wrong, what kind of problem is there, and the extent of it. We can use this to monitor a patient. Like most tests we use for diagnostic, we can use this also for monitoring for disease progression and to response to treatment. Third is we can use this to disease that may have a respiratory complication. For example, a neuromuscular disease, a patient who has a weakness. We can do a test to find out how much the patient's lung function is preserved. So patients with neuromuscular disease, we can do a pulmonary function test. Some specific surgery needs a more thorough investigation of the lung function, most important being a lung resection, and other bigger surgeries are also there. Major vascular surgeries, big abdominal surgeries can help us in cases to somewhat predict postoperative course, chances of ICU stay, and postoperative pulmonary complication. But most cases a PFT is not valuable, but for lung resection a pulmonary function test is essential to see how much of the lung we can take out and what kind of postoperative care should we be giving to that patient. We can extubate the patient, or the patient goes to a critical care, or we ventilate. These decisions are dependent to a large extent on a pulmonary function test. Also, we have to evaluate certain persons who has an occupational or radiation exposure, or medications like bleomycin, which can give rise to pulmonary symptoms. Occupational patients, like patients who work in mines, has the risk of getting pneumoconiosis for their occupational hazards. So these kinds of patients, for evaluation, if they're developing problems, if they can keep on continuing their work, we need to do these kinds of tests in these kinds of patients. And surveillance following lung transplantation, I don't know much about that, but somebody who has a lung transplantation, we have to do serial PFTs to find out, just like we keep doing creatinine in a patient with renal transplant, to figure out if the kidney is functioning well. We need to do serial PFTs at regular intervals to figure out if the transplanted lung is working well. Now, what are the contraindications to perform PFT? Now, PFT requires a bit of vigorous breathing for the patient. So every single thing where either effort, some degree of effort, or an increased intrathoracic pressure is detrimental is a contraindication. So recent myocardial infarction, unstable angina, recent thoracoabdominal surgery, recent ophthalmic surgery, thoraco or abdominal aneurysm, and current pneumothorax. But this is not limited to that. There can be other indications also, relative indications also, like a non-compliant patient. This is a sample PFT report. This is not an exact PFT report, but this is what a PFT report looks like. It has a large number of numbers, huge sets of numbers and graphs and loops. So before we start to make a sense of this thing, we have to see what are the contents. If we can group these, whatever we see in this report, into several things. So what are the components? There are four components basically in this picture that we saw in the previous slide. One is whatever we get from spirometry, one what we get from lung volumes, and then we have diffusion capacity, and then we have loops and drafts. This is in very brief the PFT procedure. So dynamic studies like the spirometry, the flow volume curves, and the peak expiratory flow rates are initially measured. Then the lung volumes are measured. Then a bronchodilator testing is done. That means the patient is administered either multiple puffs of albuterol or salbutamol, or given a nebulization. Then the dynamic studies are repeated again to see any change in response to a bronchodilator treatment. This is very, very important. And lastly, the diffusion capacity tests are done. Please note that not all of these tests can be done in a regular PFT. Lung volumes require sophisticated equipment, just as spirometry wouldn't do. Sometimes PFT comes with only the dynamic studies before and after a bronchodilator testing. This is the setup of a pulmonary function test. The patient sits comfortably and breathes through his mouth, connected to a spirometer, and this connected to a machine which analyzes, and computer which prints out the reports and the graphs. And there is a nose clip on the patient, so that all of that breathing happens mandatorily through that spirometer which the patient is, was put in his mouth. And there is a technician who monitors this thing and encourages the patient during the test, because this test is very much dependent upon the person on whom the test is being conducted. If the person is not putting in his or her maximal effort that he or she can exert, then our test results will similarly vary and our interpretations will not be correct. Now, whenever we do these things, we check it against normal values. But unlike certain things like, say, blood pressure or blood sugar, which doesn't really vary with age, 20 years back, they used to vary with age, but right now they almost do not vary with age, maybe very small variations. But here, these things varies from person to person. So my blood pressure is normal value is identical to the normal blood pressure values of most of you who are listening in. But my PFT values, my FEV1 or my vital capacity would vary. It's individual, so it has to be calculated. And the three most important factors that contributes to this variation is height. A longer person would have higher values, age, an older person would have smaller values, and sex. Male have values greater than the females. And ethnicity. Ethnicity is not very important for us, but it's an interesting point that I've learned. So if we compare between Caucasians and Africans, it so happens that the waist is at a lower position for Caucasians. So Caucasians have higher, longer torsos and smaller legs, and Africans have longer legs and smaller torsos. So since the chest size of an Caucasian is larger than the chest size of an African of the similar height, so they would have higher values. So that's just a trivia. This all of you are familiar with. Now, one patent question which you can face is that what you cannot measure from spirometry. We're not going into every detail of this picture because this is something which I expect you to know. So there are 4 volumes and 4 capacities. A capacity is a combination of more than one volume. So we cannot measure one volume in a spirometry, which is the residual volume. So residual volume is the volume of the lung, which happens after a forceful exhalation. So I exhale maximally as hard as I can. Please note my choice of word. I'm just saying as hard. So as hard as I can expel all the air out of my lung, and then the air that is there in the lung, that is the volume of the lung, that is called the residual volume. And 2 capacities, the functional residual capacity and the vital capacity, contains this residual volume. So Residual volume, functional residual capacity, and vital capacity cannot be determined from a spirometry test. We have to measure the residual volume, so we can do a full body plethysmography or nitrogen washout tests like that to determine the residual volume. Only we then can calculate the vital capacity or the residual functional capacity. So moving on. So in a spirometry, when we are doing for a, there is one single difference between doing a spirometry just to measure the volumes and to do a pulmonary function test. Not only we do our maximal inspiration and then maximal expiration, we do this maximal expiration as forcefully as possible, as fast as possible. We try to expel this air in the shortest time possible. So this is very important. I can compute my say expiratory reserve volume by expelling air, but I can take a longer time to expel that amount of air that is in my lung. But when I'm doing a pulmonary function test, I will have to exhale as forcefully, as fast as I can, all that air that is I can possibly expel. So the presence of somebody who watches over the person who is doing that test and tries to gauge the level of enthusiasm or the effort that the person is putting in, and then tries to influence her to exert more forcefully. This is very important. Patient has to use all her efforts to do this properly. So what are the things that we measure? We measure forced expiratory volume in 1 second, FEV1. That means during exhalation, how much air comes out in the first 1 second of exhalation. Forced vital capacity, what is the maximal expiration, total amount of air that comes out after a maximal inspiration, the forced vital capacity. The word force means that we are doing it as fast as we can. The ratio of the two volumes, the FEV1 by FVC. So less than 70% of it, sorry, it should be abnormal. It should be typo. Sorry for the typo. It should be obstructive disease if it is less than 70%. And FEF 25 to 75%, it means the fraction of the flow that comes out between the 25% of the FVC to 75% of the FVC. This is used to determine problems with the smaller airways. And the peak expiratory flow rate. What is the highest flow rate I am able to achieve? Many other things are measured also, but let us keep ourselves fixed to this. So this is a diagram which has a sample curve. This is the flow part in negative. That means when it is going on inspiration. This is the flow part in expiration, which is positive, and this is volume. So when I'm taking a breath in, it starts from here, and you see it's a most symmetrical curve even when we are forcefully inhaling. The different percentage points are noted. We'll disregard it as for now. Then we do a forceful exhalation. So this is the time period. We'll have to, the time scale is not there, but if we measure the first 1 second, if the total time taken is say 4 seconds, so these are almost equal gaps. So this is the 4 seconds. So you can see the maximum volume of air comes out in the first 1 second. The maximum flow rate that we are able to achieve, this is a liters per second scale, say something around 9.5. So this is the peak expiratory flow or maximum expiratory flow. This portion of the air, FEF 25 to 75 or 50 to 75, whatever we want to measure, is the area under this curve, have to be calculated by integration, are the values that we are looking for. And this is the total amount of area under the curve represents the forced vital capacity. So how do we define severity of airflow obstruction on the calculating the FEV1 predicted? As I said, that we have to calculate FEV1 by putting in patient's height, age, and sex. So FEV1 would be, if it is more than 80%, it's a mild, 50 to 80 is moderate, 30 to 49 severe, and below 30 is very severe obstruction. So this is only by looking at FEV1, but we seldom look at FEV1 in isolation. So when we first look at FEV1, we check if there is any, if it is less than, if there is any obstruction to the outflow. And we have talked before that FEV1 by FBC ratio. Now here this picture will help us get a better idea. So this is a normal lung volumes. So total lung capacity made up of the residual volume, the expiratory reserve volume, the tidal volume, and the inspiratory reserve volume. And these three volumes, inspiratory, expiratory reserve volumes, and tidal volumes, make out the vital capacity. So these are what we are measuring. Now, if we have an obstructive disease, what happens is the residual volume increases, what we see in COPD patients, and their overall lung size becomes larger. So they have a much bigger total lung capacity compared to total lung capacity. But if we look at this vital capacity or the inspiratory reserve volume, tidal volume, and the expiratory reserve volume, they do not change so much. Expiratory reserve volume is slightly higher, but they are more or less equal. So this major contribution of this increase in the total lung capacity comes from an increase in the residual volume. Now, if we have a restrictive lung disease, a pure restrictive lung disease, then we can see that this is sort of a miniature versions of these things. All the volumes are smaller. All the volumes, if you compare between these two, all the volumes are smaller compared to the corresponding volume. Now, we can have a pseudo restriction. That means we have a smaller vital capacity compared to a normal person breathing and feel that this vital capacity is low, so there may be some restrictive lung disease. But if you look at the total lung capacity huge and enlarged. And this small vital capacity happens because the residual volume is very, very high. It can happen in patients with long-standing COPD, or if there is some amount of, if there is some amount of air trapping or breath stacking is happening, then the residual volume will become very high, and the lung cannot come out of the chest cavity. So there is a maximal amount to which total lung capacity can increase. So we will have a smaller vital capacity, but this is due to a very, very increased residual volume. Now let's have a look at the graphs. Let's enlarge our areas of interest a little bit. So this is a normal graph. So we have got a graph here, and we have got a flow volume loop here. So let's look at the graph. So if we look at the time taken, you can see that the maximum volume that is generated, forced vital capacity, is achieved. Most of it is achieved in the very first. So if this is 4 or 5 seconds, within 1 second we achieve most of the forced vital capacity. Then in the next few seconds, very little comes out. Now, if we have a mild obstruction, then FVC is preserved. We attain the same amount of forced vital capacity here that we achieved in a normal person, but it takes a longer time. At 1 minute, the forced vital capacity is less, and as the time progresses, we catch up. If we have a purely restrictive, severely obstructive disease, in this case, the slope is also lower, and we also are not able to achieve the full vital capacity because it takes so much of time to exhale. We cannot exhale maximally because we have to take the next breath. In case of a restrictive lung disease, this curve looks very similar to the one which is a normal curve. However, this FVC is much lesser. Now, if we look at the flow volume loop, this is how flow volume looks. We have seen that because of the FEV1 achieving most of the vital capacity. Now, if you have mild obstruction, what we will see is that a curve which fits inside the normal curve, and the diagnostic feature is this coving, that this scalloping of this area during the expiration phase. So expiration drops rapidly and then continues for some time. Here, this almost falls off in a straight line. The flow. This is the flow. Now, if you have a severe obstruction, then we are failing to achieve the forced vital capacity, and the coving is severe, and the peak expiratory flow also very much reduced. If we have a significant restrictive disease, then it just like a miniature, the curvatures are the same. Only thing is that our forced vital capacity is much smaller. The shape is the same and there is no coving. Large airway obstruction. This is not a detailed discussion. This is very a brief discussion. The usual discussion includes whether that is intrathoracic or extrathoracic. So not going into detail. We have an intrathoracic obstruction inside a lumen of a large airway. Say we have got a lung tumor. Then what will happen is that this obstruction will have a different effect during the phases of inspiration and expiration. As you can see, during the inspiratory phase, this line, this is the inspiratory line, almost follows the normal line. Because what happens during the inspiratory phase, there is a negative intrathoracic pressure, and that tends to dilate the airways, because inside the airway is negative pressure, outside is more negative pressure, so the air coming in tends to dilate the airways. However, when the patient is trying to breathe out, there is pressure outside of that airway is much higher, and it tends to compress the airways. So we see that there is, this curve differs very much, and the flow is much reduced. Whatever the total volume, this flow rate is much reduced. We are not able to reach a peak airflow rate like a normal person. Now, if we have a fixed extrathoracic airway obstruction, say we have got a patient who has got some kind of constriction outside of the lung, we have got a tumor compressing on the windpipe, or we've got a tracheal stenosis at the glottis level, or on top of that we've got a tumor or something, then what will happen is that this constriction will remain fixed throughout the inspiration phase and the expiration phase. So both the inspiratory flow and the expiratory flow is going to be much lesser than a normal person. Now let us look at a few sample cases. It cannot be interactive so much because we cannot interact right now. So this is a case one. What we have is a, let's magnify a little bit. So smoker presents with progressive productive cough and dyspnea over 3 months. Thin patient appears comfortable. Vitals are okay, except there's a bit of tachycardia. There is a small degree of desaturation, diminished lung sound towards both the lungs, and regular rhythm, no murmurs and JVP. This is a straightforward case. If we look at the X-ray, okay. So let's have a look at the X-ray. As you can see, the lung fields are quite longer. The domes of the diaphragms are flattened. You can see both the claustrophrenic angles. The cardiothoracic ratio is small. The heart appears long and tubular, and these areas are quite dark. Now look at the spirometry values. First, look at the FVC. Now look at, please note that the whatever we are seeing here. So this is the reference value. So this is the value the patient should be able to achieve. We have one pre, and this pre value expressed as a percentage of the reference. Then we have a post value, which is expressed as a percent of the reference. Now this pre and post is after giving a bronchodilator. We have to given, they have done pre and post 4 puffs of salbutamol. So FVC predicted is 2.8 liters. Whatever we found pre-treatment is 2.3 liters. That is 61% of the predicted, and post is 2.5, 66% of the predicted. So what we can see here, that there is quite significant reduction in the FVC. There is very significant reduction is FEV1, which is 31% of predicted. Post-treatment it is 42% of predicted. So there is a significant obstruction, it seems, and there is no response to a treatment. So this is one important thing that you have to remember, is a response to treatment. So if we are having a patient who is responsive to a treatment of bronchodilators, that is, can we classify this as asthma? The answer to that question is that if there is a significant response or improvement in the spirometry parameters after giving a bronchodilator, we have to see a change of at least 12% to say that the patient has asthma. and not a obstructive lung disease. So now we look at the FEV1 by FVC ratio, which is 52% of predicted. So this is much lesser than the 70%. So we can now say that the patient has a restrictive lung disease. Now peak expiratory flow is also quite reduced. We can see this graph here. We can see that the peak expiratory flow rates are lower, and there is coving of this graph. So we know that the volumes are less. Now you have to if you have to differentiate between chronic bronchitis and emphysema, we have to look at the lung volumes. So here we see the reference lung volume. The total lung capacity should be 5.6 liters. Here we have got 7.1, that is 120% of the predicted total lung capacity, so which is quite high. The vital capacity is little reduced. You can find the answer why the vital capacity is reduced in spite of having a larger total lung capacity in the answer when you look at the residual volume. So this is more than twice of the predicted value. So we have got a much higher residual volume. Sorry, the FRCA with 170% of the normal value. So in the post expiratory state, lungs are itself quite dilated. There's a lot of air post expiration, so this patient cannot have a large tidal volume. Now we look at the diffusion capacity of carbon monoxide. Predicted value is 31. What you have found is 23. It is 73% of the normal. So since the patient has a COPD, we're seeing that there is a reduction in the diffusion capacity. Now, how do we explain this reduction in diffusion capacity? It is due to the loss of elastic tissue. The number of total gas exchange area is actually less in a person with COPD. So since the total gas exchange area is less in a person with COPD, we are seeing a fall in the DLCO. Next case is a 32-year-old animal trainer, progressive dyspnea and dry cough over the last month. Appears to be in a little respiratory discomfort. Heart rate is high, 104. Respiratory rate is high, 28. Saturation is 88% room air. On auscultation, fine crackles throughout both lungs, normal JVP. Now, if we look at this X-ray, you can see that both the lung fields is much whiter than we are usually seeing. In the perihilar area, there is a bit of blackish area, but as we go to the periphery, the large amount of lung tissue comes in the line of the X-ray, and these are filled with uniform white opacities on both the sides. So there is some pathology which is affecting uniformly both the sides. Now look at these spirometry values. So what we have here is that the FVC is very much reduced, no response to a bronchodilator. The FEV1 is also very much reduced, and FEV1 by FVC ratio is 94%. So we have a severe reduction of FEV1, and FVC is sort of normal. FEV1 by FVC ratio, both the FVC and FEV1 is reduced, and FEV1 by FVC ratio is normal. So this is the case of restrictive lung disease. Here also we can see that there is a restrictive pattern, that this graph resembles a normal graph, but it's smaller in size in all the dimensions. Let us confirm by looking at the lung volumes. You can see all the lung volumes, the total lung capacity and the vital capacity, the FRC, everything is reduced. So there is a significant restrictive lung disease. And its restrictive lung disease can happen due to some pathology in the lung, or it can happen due to some pathology in the chest walls or the neuromuscular system, or the system that helps in expanding the lung. So we have got one clue in this X-ray that there is something definitely wrong with the lung parenchyma all over. And we also look at the diffusion coefficient of the carbon monoxide across the pulmonary membrane. We can see that it is only 38% of normal. So there is something significantly wrong with the pulmonary parenchyma, or the gas exchanging surface. Now, if we come back to this history with an animal trainer and progressive dichroic dyspnea over the past 1 month. So this can be a case of some sort of allergic reaction to inhaled hairs or whatever from an animal. So this is consistent with the patient's occupational history. So possibly we need to withdraw that stimulus, and some sort of steroid or things may be necessary in this patient. Let us go to the next case. 15-year-old boy with a history of spinal cord injury presents with dyspnea for 2 months. So long history, and significant, we have a history of spinal cord trauma. There is mild respiratory discomfort. Oxygen saturation is slightly down. Heart rate is almost okay. The chest is clear to auscultation. There is no rhythm is regular and there is no murmur. Now let's look at the PFT. So these are sort of borderline. We can see that FBC and FEV1 both are reduced to about 72% and absolutely no response to bronchodilators. And the FEV1 by FBC ratio is slightly reduced, but it's much above the 70% that we need to have to call it an obstructive disease. So we're mostly dealing with a restrictive pattern. Our flow volume loop also confirms that it is a small sized version of the normal loop, less peak flow rate, and there is no coving. So this is the case of respiratory disease. We look at the lung volumes. We can see that all the lung volumes are diminished, and the ones that require more volition have got reduced volume. The TLC is 60, vital capacity is 21%, the FRC is 72%, it is slightly high. Now, when you look at the diffusion capacity, so we look at the diffusion capacity, it is preserved at 97%. So we have a restrictive lung disease when the lung parenchyma appears to be normal. We do not have a chest X-ray, but let's assume that we have a reasonably normal chest X-ray. So this is something to do with the chest wall or the neuromuscular system, which helps in the lung expanding in the effort of the breathing. And we have a history of spinal cord trauma, so that makes our life easier. We can easily say that this is a cause of restrictive pattern due to a neural injury, spinal cord injury. Now this is the last case. We have got a 40-year-old man with a history of smoking and presents with progressive dyspnea and leg swelling. Patient is obese, has a BMI of 35, BP is slightly high, saturation is 87. Chest sounds diminished all throughout the both lungs. The regular rhythm, JVP, is mildly elevated. We also have pitting edema on the upper shins bilaterally. So obese patient who is presenting with progressive dyspnea, obese, and hypertensive. I am not sure if he's on medication, and also a smoker. The low saturation, abnormal sounds throughout both lungs. So whatever is happening is affecting both the lungs. Slightly raised JVP, bilateral pitting edema bilaterally. Now, if we look at this X-ray, what we can see that we can see a portable X-ray. So, but we can still see the apex of the both lungs. So this is probably a PA, posterior anterior X-ray. I don't know if it's an ECG lead, so I'm not very sure whether it's a PA view or AP view. But since I can see the apex of both the lungs above the clavicle, and the scapula is outside the lung view, I would go with the notion that this is most likely a PA view. So if this is the PA view, the lung sizes are very small. We expect in a 53-year-old male to be higher. And you see there is a large amount of white shadowing in these areas. So these are probably, the person is quite large bulk is contributing to these white shadows all overing, and there are a bit of white shadows all over the lung fields also. Now, if we look at spirometry, the FBC is 73%, no change with treatment. The FEV1 is 37% of predicted, and there is a little bit of change with treatment. And the FEV1 by FBC ratio is 40. So we have definitely a restrictive pattern here. But when you look at this flow volume loop, we see that there is a coving pattern also. So it appears this patient has both restrictive and obstructive pattern, and this obstructing pattern is not responsive to a bronchodilator. So COPD plus some kind of restrictive lung disease. This restrictive lung disease can possibly be explained by obesity. Obesity only we'll see. Now let us check at the lung volumes. You can see that the lung volumes are markedly reduced. The vital capacity is a bit more preserved. The inspiratory capacity a bit more preserved. So efforts are a bit more preserved, but other volumes like FRC and the residual volume are greatly diminished because of the obesity, and also reflects in the smaller size of that lung. So diffusion capacity is not fully preserved, partly preserved. So we have got some problems with multiple problems here. So we have got both mixed obstructive and restrictive disease. We have got some problems with diffusion also. Now, without having more histories, it's not possible. But if we corroborate the histories, patients had the long-standing history of smokers, so probably some degree of COPD is there, and there is bilateral pitting edema plus crackles all over the chest, so there is chest infiltrates, and probably there is extra lung water. Probably the patient has some degree of heart failure. The heart size is not too large, so there can be a bit of a heart failure. Because of this, we have got extra lung water and shadows all over and abnormal heart sounds and pitting edema and slightly raised JVP also. So this is the possible explanation of this test. So with this, we end our discussion on chest X. We'll take the questions later, not now. Now let us move to the third topic of today, which is CPET, cardiopulmonary exercise testing. This is an upcoming topic. I mean, we've been talking about for the last few years. This is something coming up in a big way in the first world countries. But the problem is that I have neither seen one nor done one, just read a little bit. So for some time, I will pretend that I know something till I get the questions from you. So surgical stress, basically, it causes an increase in metabolic requirements, increased workload on organ systems, and organ failure when reserve is less. So if we are dealing with a patient where the surgical stress is more, that is a bigger surgery, longer surgery, much blood loss, you know the stuff, and a patient whose reserve is less, that means the organ which cannot support the increased metabolic requirement, we are going to have complications, as simple as that. So if we can find out beforehand that how much organ reserves we have, it would be easier for us to plan the procedure, to see if we can improve the situation, and also to find out what kind of post-operative care we might be necessary. So this stress is a coordinated functioning of all the major systems, so we'll be considering on the pulmonary and the cardiovascular system. If you look at all these previous tests, also PFT and this cardiopulmonary function testing also, and a large number of tests that we do preoperatively, is to figure out if the patient is able to deliver oxygen to the tissues. Now, this involves several steps. One, this involves air getting into our lung and getting out of that lung. This is step number one. Step number two is gas exchange in the pulmonary capillary bed. Third is the flow of the blood to the tissue level, goes to the proper organ, good capillary bed and gas exchanging happening there, and then it should be able to be utilized by at the tissue level, at the mitochondrial level. So problems can happen at all these stages, and this CPEX is one of those tests that allows us to test all these steps. So what we do when we assess the functional status, we check pulmonary function and we test cardiac function. But the conventional assessment has a few problems because we are assessing the systems in isolation. We do not look at the whole body under stress. When we are doing a CPEX or CPET, whatever you want to call it, we are testing the body, how the system works under stress. So it's like a dress rehearsal that we are doing, and we are able to much better understand how much the patient is likely to cope or not likely to cope. And so also these are not done under stress. They lack sensitivity and is subject to inaccurate assessment. Now, why CPET? It is a most reliable and objective test for the evaluation of the functional ability. By measuring the dynamic gas exchange during graded exercise, it can identify potential deficiencies within these systems. It is non-invasive and integrated assessment. Now, this exercise physiology is a very huge subject, and actually it is possible to define many of the deficiencies and find out where the deficiencies happen. I neither have the knowledge nor the time to go through all of this, but we would cover the most important points. So it is a basic concept is that metabolism is aerobic is oxygen supply is adequate. Now, when demand is more than supply, we will move to anaerobic metabolism. Now, when we have an aerobic metabolism, we have 1 unit of glucose, and it uses 6 molecules of oxygen, and it produces 6 molecules of carbon dioxide and a large amount of ATP. When we go to the anaerobic metabolism, this same one molecule of glucose produces only 2 units of ATP. So This is grossly inefficient. However, it can run in the absence of oxygen. Now, what happens when we go into anaerobic metabolism? We produce lactic acid, it causes lactic acidosis, and it ultimately causes muscle fatigue and prevents us from whatever you want to do. So even if I try, I cannot run a marathon because of this lactose acidosis which set in, and whatever my will is, my muscles will not comply. So fixed equation, this is the VO2, that means the oxygen uptake. Let us begin with the fixed equation. So what we have is the stroke volume into heart rate. This means is the cardiac output, and that is the flow of blood, and this is the concentration of oxygen in the artery minus the concentration of oxygen in the central venous blood. So this is the oxygen uptake. So X amount of blood is going in, and when this X amount of blood comes back to the heart, we see that Y amount of oxygen present in that has been extracted. So X into Y is the amount of oxygen that has been taken up. So this is very important because this oxygen uptake can be reduced due to problems with all four of these steps. Now, if we cannot increase stroke volume, we may not be able to increase stroke volume if we have a problem with the myocardium. The myocardium, we have got some kind of cardiomyopathy, stuff like we have got ischemia, so we cannot increase stroke volume. So if we cannot increase stroke volume, our option of increasing cardiac output is to increase the heart rate. Now, heart rate may not be able to increase if there are problems with conduction system, if the patient is on a pacemaker which is not rate adjustable, if the patient is on drugs which control heart rate, which is quite common, like patients in with beta blockers, and there can be some neurological diseases in which the heart rate can be pretty fixed and does not move much. So we have to increase both heart rate and stroke volume to increase our cardiac output. It is actually possible to increase our cardiac output by a large extent. Our normal stroke volume is around 70. We can increase our stroke volume to at least double it. And our heart rate is around 60 to 70. We can increase our heart rate to 150, 160 to 2.5 times. So this increase our stroke volume by at least 2 times and heart rate by 2.5 times. So we can increase our cardiac output by at least 4 or 5 times at least. Now look at the oxygen extraction. Oxygen extraction is something that also increases a lot under under exercise. So CaO2, the concentration of oxygen in the blood, arterial blood, the amount of oxygen can be less due to various reasons. It can be less because of impaired gas exchange at the alveolo-capillary membrane. It can be less like things as common as anemia because there is simply less hemoglobin to carry blood. Venous oxygen extraction, CVO2, can be poor. We can have blood coming back to the heart with a lot of oxygen in it. If we are unable to extract that oxygen, it can happen if our blood vessel is not supplying those organs. If there is some kind of stenosis and we are not supplying those things, we will come back and not being able to extract that oxygen. If there is not enough capillaries there, people who exercise develop more capillaries so they can extract oxygen more efficiently. So an untrained person, deconditioned person would have less capillaries and their ability to extract oxygen is lesser. And other things like mitochondrial dysfunction, drugs, cytotoxic drugs can reduce this. Now, probably the most important concept is VO2 max. So the maximum oxygen that I can take in is VO2 max. So this includes all these steps that I have to take into my lung and put it into my blood and transport it and then utilize. So the maximum amount that I can utilize is VO2 max. VO2 peak is the peak uptake that we can attain regardless of whether a plateau in oxygen consumption is seen or not. So VO2 max and VO2 peak is they're quite similar and often used identically. So this is work. This is the VO2. So when the patient is doing is in a steady state of mind, like I'm sitting on a chair and I'm not talking, not consuming much energy, the VO2 is a flat line. Now, as I increase my expenditure of, try walking, try running harder up a stairs, my oxygen consumption climbs and climbs and climbs and climbs. to a state when I am no longer able to increase my oxygen consumption any further, and then this plateaus. So this line is this amount of VO2 is the VO2 max. So we have achieved a flat plateau. That means it is no longer possible for me, even when I'm increasing my work, to absorb and utilize more oxygen. So this is VO2 max. But most of the people like us are not able to achieve VO2 max because fatigue sets in much before that, and we stop somewhere around, say, here. We stop somewhere around here. We have an upsloping curve, and then we stop work, and our oxygen consumption falls rapidly. If we stop working here, our oxygen consumption will fall like this. Then we stop working and come to the baseline. It will remain slightly above baseline because of something called oxygen deficit. This gap is slightly less than this gap because we have a little bit of oxygen deficit at the end of a strenuous activity. So this point, we will call it the VO2 peak, because this is the peak oxygen consumption that I am able to achieve. So this is peak and this is max. So for most purposes, this VO2 peak would be equal to VO2 max if we are not able to reach this area, go beyond this area, which is true for most of us. So for us, the VO2 peak and VO2 max would be identical, but it's important to keep in mind that though they're identical in most cases, they are not identical in all cases. They're measured by milliliter per kg per minute. Anaerobic threshold. So anaerobic threshold is when anaerobic metabolism begins. So I am increasing my effort, I'm increasing the amount of work that I'm doing. There will be a point of time when the blood lactate level will continue to increase. It is actually previously, when the first exercise testing started, an arterial line used to be put in and multiple blood samples taken in to measure lactate levels. Right now we don't do it, we do it by other methods. We'll look at it later on. Now, what happens to metabolism when we hit the anaerobic threshold? One common misconception is that it is the point in which our metabolism switches from aerobic to anaerobic. Not at all. If we looked at the previous graph, you can see, well, till we are reaching, say we have reached VO2 max, then even after we have reached VO2 max, we continue to consume at that same level. So we are consuming a lot of oxygen. So we are undergoing aerobic metabolism also. But this aerobic metabolism is not enough to provide all the energy that we are spending. So some amount of the energy is coming from anaerobic metabolism. So after we have hit anaerobic threshold, both aerobic metabolism and anaerobic metabolism will continue to increase. Aerobic metabolism will continue to increase till we hit VO2 max. After we hit VO2 max, the oxygen consumption plateaus and aerobic metabolism also plateaus. But anaerobic metabolism continues to increase if we can continue to increase. So what exercise does? Exercise can increase aerobic threshold and VO2 max, but they cannot change it to a large extent. Most of the people, if we can increase, we will probably increase it by 10-15%. 15% would be too much. So what exercise does is that they increase lactate tolerance. So we are able to continue exercising harder in spite of going much beyond aerobic threshold and going close to VO2 max or going up to VO2 max. Next concept is oxygen pulse. It is the oxygen extracted per heartbeat. So we have to see the VO2 divided by the heart rate. So this is an important parameter to determine whether our exercise is limited by the cardiac function or not. Ventilatory equivalence. In very simple terms, the ventilatory equivalent for oxygen is how much we have to ventilate to consume 1 unit of oxygen, and ventilatory equivalent of carbon dioxide, V by VCO2, is how much we have to breathe to exhale 1 unit of carbon dioxide. So these are measures of respiratory efficiency. If these are low, that means even with lesser ventilation, we are able to get in oxygen and excrete carbon dioxide. So oxygen, this is a graph of oxygen uptake, heart rate, and arteriovenous dissociation, oxygen different at difference of rest during excess levels of exercise. So in the topmost graph, we have got oxygen uptake, and along the x-axis, we have got workload. So as workload increases, we increase our oxygen uptake, VO2 max before training and after training. So you can see that there's a small change that happens with VO2 max with training. And heartbeat per minute, it also linearly increases with exercise. But if we are a conditioned person, our heart rate will be like this on the lower graph. So this is a person who is not conditioned. This is one with exercise. We will be able to maintain, because what happens with exercise, many of the benefits, we are able to increase our cardiac output, our stroke volume. So exercise helps us to increase our stroke volume, so we can manage with a lower heart rate. And you can see that AV gradient, as the workload increases, the arterial content is of course constant, because we are getting in 100% saturation does not fall in usually patients, but we are extracting more and more and more. So the gradient, the difference between arterial and venous content of oxygen increases with time. Now, what determines VO2 max? It's mostly age, gender, and most importantly, genetics. So as I can change my genetics or my gender. So what affects my VO2 now and 20 years before and 20 years, well, if I pass this COVID era successfully, then what will happen to my VO2 max? It's mostly determined by my age, and to a small extent by my effort. This is also somebody who runs the marathon successfully, trains 2 hours, 6 hours a day. They also have a reduction in VO2 max as they become older. So what about the test? There is an exercise and there is a metabolic cart. So the exercise is a treadmill, stationary bicycle, or an arm crank for patients who are very sick or have severe osteoarthritis and stuff like that. And the metabolic cart have got a gas analyzer. They have got a pneumotachograph, which measures the breath by breath gas volume with a computer, ECG with STT analysis and graphical displays, and very importantly, resuscitation equipment and personnel. This is how it looks like. So this person is on a stationary bike. He has got a BP cuff. He has got ECG leads connected here, big monitors with lots of graphs coming in, and he's breathing through a mask, which is connected to the gas sampling. So what we are doing, we are measuring the concentration of the gases which are going in and out. Also, we are measuring the volume of the gas that is coming out. And this treadmill is a program to increase its resistance gradually in a step manner. So ECG, BP, SpO2, mouthpiece or mask will monitors. In the beginning, we'll have a baseline data. So the patient will sit just like I'm sitting on my chair now for some time to gather the baseline data. Then there is 2-3 minutes of normal level work. That means the person pedals without much resistance. Then the load is increased gradually by say 10 to 20 watts per minute. And the test lasts for 10 minutes. Now here the, like if I go on a test and say a marathon runner goes there and an 80-year-old person goes there, sorry, the workload has to be increased in a different fashion. And we have to start at a different level, because the beginning and the end will be different in different persons. So we either reach a sub-maximal exercise, we may not reach, we may reach sub-maximal exercise. Total time is 10 minutes, then there is a cool down period. We terminate if the test is completed, patient consists of, has severe problems like MI, ECG changes, ectopics, blocks. If there is significant desaturation, dizziness, etc. Now, patients do not get hypotension when they exercise. If they exercise, their baseline, their resting blood pressure goes down, but during exercise, the heart rate goes up. So patient having some degree of hypotension, significant hypotension, or a very significant hypertension, both of these are indications of terminating the test. We get oxygen uptake data, VO2, maximal oxygen uptake, VO2 max, VO2 peak, ventilatory equivalents, anaerobic thresholds, and O2 pulse, and a lot more. But this is what we are going to discuss. We also get data on how on the from the ECG, heart rate, blood pressure, arrhythmias, etc. Now it tells us if the cardiorespiratory system is able to deliver oxygen to the peripheral tissues by the VO2 that we are able to achieve, and the ability of the tissues to utilize that oxygen. This is a pretty colorful graph. This is a typical 9-panel CPT display. We will not try to explain these things for one of the primary reasons that I will not be able to explain all these panels. So we've got simpler panels to help us understand. First is anaerobic threshold. It is the time when anaerobic respiration starts. That means oxygen supply is not able to meet all our energy demands. So we have got two lines here. One, this dotted line, which starts lower than this small dashed line, overtakes it and goes over. This small dotted line, which runs lower and parallel to this dotted line, is the VCO2, that is the expiration of carbon dioxide. And the topmost line is the VO2. As the work rate increases, there is one point of time where we can see that there is a sudden jump in this carbon dioxide production. And at some point of time, it overtakes and continues to rise. So the anaerobic threshold is the point when there is a sudden jump in the carbon dioxide production. Now, when you look at anaerobic metabolism, the anaerobic metabolism produces APT and pyruvate. It does not produce carbon dioxide. But when you go to the TCA cycle, this pyruvate becomes lactate, and this lactate is neutralized, forms bicarbonate, and this bicarbonate part of that carbon dioxide goes out. So there is a sudden increase in the carbon dioxide production. So the moment when there is a sudden increase in the carbon dioxide production, that is the anaerobic threshold. Now, it's not the point when it crosses over and becomes more than the VO2. The sudden jump in VCO2 is the point of the anaerobic threshold. This is called the modified V method because it looks like a V. We'll go to the next slides and see. Okay, so this is only the carbon dioxide curve. This is the upper points are joined by this blue line and the lower points are joined by this red line. So this point of intersection where it suddenly starts to rise is the VO2. This is plotted as in contrast to VO2 on the x-axis. So this point is the anaerobic threshold, and I look at it's at a VO2 of approximately 2.25 liters. Now, this is a graph when we're looking at the ventilatory equivalence of VCO2 and VO2. Here we see that the amount of breathing that we need to do for a particular work rate suddenly increases here at this point. Now, this happens because our ventilation is mostly geared for carbon dioxide production in the body. So because there is a sudden rise in carbon dioxide production, but not so much rise in the oxygen production, our ventilation increases, and it increases at a rate greater than the rate of increase in the oxygen consumption. So if we compare the oxygen consumption to the ventilation, we will see that there is a sudden jump in ventilation compared to an increase in the oxygen consumption. So this VO2 graph shows a sudden rise at the anaerobic threshold. This is another way of calculating the anaerobic threshold. Now it occurs at approximately 50 to 60% of VO2 max in normal individuals. Now, if I go on a treadmill and I try to do this test, most of us people who are not used to exercising would give up the moment we hit anaerobic threshold. Lactic acid starts to build up and I feel too tired to continue. So it would appear that I've got an anaerobic threshold of 90% of my VO2 max, and it would be like, fantastic. I must challenge Usain Bolt the next time. But it's not true, because we have to compare the VO2 max also. How much is my VO2 max? So the benefit of AT is that it's a well-defined physiologic point that can be measured in most patients, 50 to 60% of VO2 max. Now we'll go towards interpretations. Now, if you have a low preoperative anaerobic threshold, that means that correlates with the postoperative mortality. It should naturally follow, because what it tells us that we do not have enough oxygen delivery capacity of a body to to accommodate a greater amount of work. So when the body goes into the repair mode, it needs more energy. The body will not be able to supply enough oxygen, and body will go to anaerobic metabolism and acidosis. However, there is no clear agreement on the best single predictor of outcome. Now, these are two values that you will have to remember and regurgitate during examinations. So VO2 peak, we're talking about VO2 peak because this is what we'll achieve. We know that this is not VO2 max, what should be achieved. So a threshold 15 milliliter of oxygen per kg per minute, or anaerobic threshold of 11 milliliter of oxygen consumed per kg per minute. If it is lower than this, then the patients have a much higher risk of complication after having a major surgery. Now, if you look at this particular value of 15 milliliter per kg per minute, you will see that this is almost exactly 4 met. If you consider 1 met to be 3.5 to 4 milliliters of oxygen per kg per minute. So this also sorts of corroborates with our usual clinical practice of taking up patients who can undergo work of 4 mets or higher without any further cardiac evaluation. So oxygen pulse and cardiac output. Let us assume we are dealing with a person with a fixed heart rate. We sometimes do get these patients on a beta blocker, or there is some abnormality with the heart rate, so that the heart rate is not able to increase. So in that case, if the VO2 oxygen consumption continues to rise, then remember the fixed principle, then it must be because of an increase in the stroke volume. So if it is not happening, it remains low during exercise, then that person is not able to increase its stroke volume and is dependent on an heart rate to increase and meet an increased oxygen demand. So if we cannot increase stroke volume, they will exhibit tachycardia faster in response to a workload. This is what we see in people with a damaged heart. So their tachycardia sets in faster in response to an increased workload, because they have to try to deliver higher oxygen demand. If we are doing an STT lead analysis, which are doing continuously and corroborate with our findings, we will see that if we have ischemia detected after we hit the anaerobic threshold, then the chances of complication are less, because we will be able to supply enough oxygen to meet the body's demands, and we are unlikely to get STT changes because of the post-surgical stress. However, if ischemia occurs before we hit the anaerobic threshold, then the chances of postoperative complications are higher. Especially true if the anaerobic threshold is low, which is going to happen in sicker patients. Now, in those patients, it may be important to take steps if we can reduce ischemia that can improve cardiac function, and in that case, they can also improve the anaerobic threshold also. Patients who are on beta blockers have a low anaerobic threshold and their oxygen pulse is low because the heart rate is itself lower. So they're not being able to increase their heart rate. If we stop the beta blocker, we can see that there is an improvement in AT, because we are able to increase the heart rate to increase cardiac output, but there is no ischemia or little ischemia. In that case, we can proceed with stopping the beta blocker. But however, we stop the beta blocker and still AT remains low, and since we have withdrawn the beta blocker, we detect ischemia. So that is a problem situation. We have to look for safer options of surgery, different kind of surgery, and we have to talk about stress of surgery and recovery, how to modify the recovery position, and if it is possible for us to improve coronary perfusion by any other means. Use is basically to optimize the use of critical care beds, so figure out who can be sent to the ward and who needs critical care, guides the choice of therapy. We've seen a few choice of therapy, and against radical but potentially life-saving therapy. If we have a very poor result, we know that the chances of complication is very high, then in those cases, very radical surgeries which are potentially life-saving therapies, should be avoided. Thoracic surgery, I think it will discuss later on. Preoperative CPX testing is not necessary for all patients, but if there is predicted FEV1 is less than 40% or total lung capacity, TLC, or sorry, transfer capacity of carbon monoxide is less than 40%, in those cases, if the predicted FEV1 is less than 40%, we have to do a CPX testing. And patients who are proven to have a VO2 peak of less than 15 minutes per kg per minute, in those cases, okay. In those patients with a low VO2 peak, we have to do a CPX. It can be useful. If it is so, the chances of complication after lung resection is higher. Non-cardiac surgery, in major intra-abdominal surgery, anaerobic threshold less than 11 milliliter per kg per minute, the chances of post-operative death is very high. It is 18-fold to the normal one. So 4 major types of surgeries are in which surgeries are used: major vascular surgeries, abdominal surgeries, etc. And this is one study. Let's just go to the conclusions. If it was, the results were good, then low risk of complications managed in the ward after surgery. But if the inadequate it is there, but ventilated equivalent of oxygen is high, and we have got evidence of myocardial ischemia, in those cases, high dependence area or ICU. However, if it is very less, then the patients will go for intensive care surgery and the overall mortality rate is higher. Now, these are fuzzy things. Direct the patient to the appropriate level of postoperative care, ward, high dependency units, critical care, and preoperative preparation of that patient. We can sometimes pinpoint whether that is a respiratory problem or the cardiac problem. One of the things is to look at the ventilatory equivalents. If the ventilatory equivalents are very high, then obviously there is some problem with gas exchange. And if the heart rate response is very high, heart rate response happens very further, then it is most likely the cardiac cause. In a normal person, like if I have to go on a treadmill, so it is mostly my limitations of my heart to increase cardiac output further would be my limiting factor rather than the lung. So if we look at the maximum mandatory ventilation that I can achieve, and if we look at the maximum ventilation achieved during the treadmill test, during the cardiopulmonary exercise test, if there's a gap of 15 liters, then there is adequate pulmonary reserve. So if a person stops before that, so we know that the lung-wise that person is okay, the limiting factor is cardiac. And also if the patient says that the patient stopped because of tiredness, then there is most likely cardiac. If the patient says because of respiratory distress, then this is due to dyspnea, then this is due to lung factor. If we have got a low cardiac oxygen pulse, we know that there is a poor cardiac function. And if there is inducible myocardial ischemia, then we know that appropriate cardiac medications and further cardiological investigations would be necessary. If we have elevated ventilatory equivalent throughout the test, as I mentioned, we need respiratory insufficiency and preoperative medication changes may be necessary. Vigorous physiotherapy in the postoperative period will also be necessary. But the problems, one is alterations in the level of fitness. So if when the patient comes for the test and the patient comes for the surgery, that can differ, especially in illnesses which progress fast. The reliability of the equipment, the lab, intra-observer varieties are there. There are variations in protocols and learning effect with repeated testing, because we are not doing it. So if we get it now, we will have problems in the initial few things. Also, the effort level is very, very important. If the person is not motivated enough, is not going to put in enough hard work for us to have data to interpret. Now, if we have an 80-year-old person, then we have got a predicted VO2 max which is less than 20 milliliter per kg per minute. So if we have an 80 at say 10 milliliter per kg per minute, it's going to be normal, though it's going to be lesser than our lower cutoff values for complications. But if we look at the age, that 80 does not look so bad. However, if we look at for a 20-year-old person, this is going to be very, very significant. We will not go into that report. We have sort of covered. So how it's going to help us mostly with our decision making in terms of surgical risk is incomplete. And there is association between a limited exercise capacity and the risk of post-operative complications. And also there are risk scores which are available for preoperative stratification of patients. Now, what we do not have is the strength of this. It needs to be validated for each surgical procedure. Now, sort of what we have is general for either cardiac surgery, thoracic surgery, or major surgeries, but we do not know whether it's a big laparotomy versus a thoracotomy, how it's going to be more appropriate for one, or maybe appropriate for all of them. And if the values significant, is going to differ for one from the other. And we also do not know how strong is this association between exercise capacity and perioperative risk. It can vary with surgical types. So, three quite long and tedious lectures. Thankfully, I've been able to complete it.
Yeah, thank you,
Ah,
Palash. Thank you very much. I think a very detailed description of each of these things, and they are by itself pretty long, and you dealt with it. Only thing I'll tell everybody, especially the students, these sessions are being recorded and they'll be put up in the HCP forum. So if you feel that you need to go back to any of these things, uh, you, once, I think maybe after 24 hours or 48 hours, this will be put up on the HCP forum website, and you can some of the details can be picked up from there. Okay, I think we'll quickly go through some of the questions for you, Palash. Uh, I think from chest X-ray, Dr. Chiranjeev Bagchi wanted to know how to differentiate between the inspiratory and an expiratory film.
well, I think we have covered it in quite a bit of detail. In an inspiratory film, the lungs are going to be bigger compared to an expiratory film. If we have not ordered anything special and it was not a portable X-ray, then if it is taken in the X-ray room, it is going to be an inspiratory film. We will see 6 or 7 anterior ribs in that, so chest will be adequately expanded for that person, because if we consider the ribs, we take into the height of that person into account. So that's how we differentiate.
Yeah, I think it again. This is again the reason I think you can go back to that website and check it.
And just check it. Huh?
Yeah, it's all there. I think Dr. Shinu Kaur wanted to see a X-ray of a COPD. We will put it up on the website.
I think, can I just come in? I think there
Yeah.
are few requests of those specific things. Now, nowadays, it is extremely simple to see an X-ray of any disease. You just open up your browser, use your search engine, and just type whatever you want to see. And when you get the results, you will see web, news, videos, images, etc. You just click on that image button, and you will have plenty of images. You just
Absolutely.
open up the images and see.
Is it possible, Dr. Dilip, one of our students, is it possible to suspect right atrial or a left atrial enlargement from a chest X-ray?
Yes, absolutely, it's possible. If we go back to the cardiac silhouette, the right atrium is on the right side of the spinal shadow of the spines. So if there is a right heart enlargement, you will see 2 separate lines. LA will cause an enlargement of the left side, and the left atrial appendage is mostly visible. My knowledge of chest is a bit hazy, but on the right side and left side can be separate, can be figured out.
Absolutely, yeah. Dr. Niladri Mukherjee, he wants to know what is the minimum significant value reduction for DLCO to be commented.
I cannot exactly answer this question. What
I think,
percentage exactly?
I think this is more important in thoracic surgery, where you're looking at that 40% value. So it should be at least greater than the 40% value for a meaningful, even for a.
That is a cutoff value for complications where you can proceed and not proceed.
Dr. Shantanu Tripathi was also a part of the session. Thank you, Dr. Tripathi, and he has congratulated Palash for the excellent session. Dr. Shom Sindhu, one of our students, wanted to know in which condition VO2 peak is not equal to VO2 max.
Well, VO2 max would be achievable in patients who are very fit, who can continue to exercise till they hit a plateau in that oxygen uptake curve. So most of us who are not trained athletes uh, would not go up to that point where we are able to sustain an exercise because our lactate tolerance is not there. We would become muscles would become fatigued much before that with a smaller amount of lactate. So in those cases, VO2 max and would not going to achieve, and VO2 peak and max would be the same. So in other cases, it's going to be higher. VO2 peak is whatever we are achieving. VO2
Yeah.
max is when we are achieving a plateau
Right.
in the oxygen consumption.
And two very senior people have questions for you, Palash. Dr. Gauri Mukherjee, Professor Mukherjee wants to know how to diagnose pneumomediastinum in a chest X-ray.
Well, I do not have an answer to that, but the quality, well, we can look it up on the web, but
I think
yeah,
we will
pointers,
an answer. Yeah,
if there is enough air, it's going to give us a black shadow,
correct.
and it's going to cause an widening up of the mediastinum. In an erect posture, it's going to be the upper mediastinum because the air is going to go up there.
Right. And thank you, Amnadi, for again being with us. Thank you for always inspiring us. She wanted to know, Professor Goswami wanted to know whether there are certain bedside assessments of lung function.
Well, I think it's a very favorite of examiners. What we usually do is breath holding. I personally do is breath holding. I sort of solely rely on breath holding, and nowadays we carry a pulse oximeter in our pocket and put it.
Yeah, because all those things are very well described, better described than performed, like thing like the mastic test or
Mhm.
the balloon test. I don't know what utility it actually has, and it's
I always do a breath count or breath holding. I prefer a breath holding and saturation.
right. Okay, I think if that is all, Palash, you please stay with us.
Yeah.
Thank you, Palash, for taking the trouble of doing such three hugely very beautiful, very informative sessions. Thank you very much.
So thank you everyone for joining us. Thank you, Dr. Sengupta, Dr. Kumar, for your sessions. And I would request all of you, since this is a new initiative we have started, your feedbacks are very important to us. So kindly share your feedbacks. After this session ends, you will get a mail, individual mail. So you just click onto the link in the mail and share your feedback. And once you share your feedback, this is just customary, you will get an e-certificate signed by Dr. Sengupta and Dr. Kumar. And within 24 hours, like maybe tomorrow in the evening, late evening, you will get a link through which you can visit edu.hcpforum.com, where you can revisit all the lectures of Dr. Sengupta and team. So thank you everyone for participating. Thank you faculty, and have a good night. Bye-bye.
Good night.